58-year-old woman with HER2 positive metastatic breast cancer whose extracranial disease is stable on maintenance trastuzumab and pertuzumab is found to have 3 asymptomatic, small, 1 centimeter brain metastases on a routine surveillance MRI. She has excellent performance status, KPS 90, and no neurologic symptoms. She has not received T-DM1, T-DXd, or Tucatinib previously. Upfront radiation therapy is considered the standard initial approach for managing these newly diagnosed brain metastases. Answer: true. For initial therapy of newly diagnosed brain metastases in HER2-positive disease, radiation therapy remains the standard of care, although systemic therapy is an evolving alternative for select asymptomatic patients. Continuing the current regimen of trastuzumab and pertuzumab is appropriate after local treatment of the brain metastases. Answer: true. Per patients with a new intracranial lesion and stable or responding extracranial disease, continuing the existing line of systemic treatment is generally recommended, provided it is well tolerated and a reasonable local therapy option exists. Given the patient is asymptomatic with limited lesions, initiating tucatinib, capecitabine, and trastuzumab instead of upfront radiation is an established first-line standard of care. Answer: false. While this regimen is an appropriate alternative to upfront radiation for select asymptomatic patients with HER2-positive brain metastases, upfront radiation therapy remains the standard initial approach. Systemic therapy requires appropriate patient counseling regarding the lack of direct comparative trials. Trastuzumab deruxtecan, or T-DXd, has demonstrated efficacy specifically in patients with active, untreated brain metastases in phase trial 3s. Answer: false. While T-DXd shows intracranial activity in phase 2 trials involving active brain metastases, the phase 3 DESTINY-Breast3 trial primarily included patients with stable, previously treated brain metastases. Data for T-DXd in newly diagnosed, untreated brain metastases in lieu of radiotherapy is still limited. Would treatment with T-DM1 be considered a preferred systemic therapy option over the Tucatinib-based regimen if systemic therapy were chosen instead of radiation? Answer: no. The Tucatinib combination is preferred over T-DM1 for active brain metastases due to the significant overall survival benefit demonstrated in the HER2 CLIMB trial, which specifically included patients with active brain metastases. Is routine seizure prophylaxis indicated for this patient? Answer: no. Routine seizure prophylaxis is not indicated for most patients with brain metastases from breast cancer, particularly those who have not had a prior seizure. A 42-year-old woman with a history of stage 3 triple-negative breast cancer, treated 2 years prior, presents with new-onset seizures. MRI reveals multiple brain metastases with surrounding edema, and staging scans confirm new pulmonary metastases. Her KPS is 70, and she requires corticosteroids for symptom control. Given her KPS of 70 and symptomatic presentation, aggressive local therapy such as surgical resection or stereotactic radiosurgery is the preferred initial approach for her brain metastases. Answer: false. For patients with a favorable prognosis, typically KPS greater than 70, aggressive local treatment can be indicated. However, the presence of multiple metastases and the need for steroids influence the choice. Whole brain radiation therapy, WBRT, is often considered for multiple lesions or lower KPS. KPS 70 is borderline, and multiple metastases often favor WBRT. Triple-negative breast cancer subtype is associated with a lower risk of developing brain metastases compared to luminal subtypes. Answer: false. Patients with triple-negative breast cancer have an increased risk of brain metastases, with incidence rates at or following diagnosis of metastatic disease ranging between 25 and 46%, significantly higher than luminal A subtypes. Endocrine therapy is a viable systemic treatment option for controlling her brain metastases after local therapy. Answer: false. This patient has triple-negative breast cancer, which is defined by the absence of hormone receptor expression, ER/PR negative, rendering endocrine therapy ineffective. Is it likely that standard chemotherapy agents used for metastatic breast cancer will have activity against her brain metastases? Answer: yes. Although many agents penetrate the intact blood-brain barrier poorly, agents like platinums and potentially capecitabine derivatives can show activity against CNS metastases, possibly due to increased permeability of tumor vasculature. Does this patient's clinical presentation align with the generally poor prognosis associated with brain metastases from triple-negative breast cancer? Answer: yes. The prognosis for patients with brain metastases arising from triple-negative breast cancer remains poor compared to other subtypes like HER2-positive disease. Should germline BRCA1/2 mutation testing be considered in this patient? Answer: yes. Patients with triple-negative breast cancer, especially at a younger age, 42 years old, meet criteria for genetic testing. BRCA1 carriers have an increased likelihood of the triple-negative subtype and potentially higher risk of CNS metastases.
What topic should we bite next? Comment below. Subscribe and hit the bell for instant updates. Explore our channel for more. Find more info at HemOncBytes.com. Stay current, stay curious.